The human body repairs tissue damage through a highly orchestrated sequence of biological events. This timeline tracks the 4 overlapping stages of standard wound repair: hemostasis, inflammation, proliferation, and finally, remodeling. Under healthy conditions, the biological progress indicator reaches successful closure at roughly 21 days. But this sequence is not foolproof. When the biological machinery stalls, the result is a chronic wound, a failure of the repair sequence to reach functional integrity. Clinically, a wound is considered chronic when it remains trapped in the inflammatory phase for over 3 months. Some remain unhealed for decades. This is the macroscopic reality of that biological failure, a typical diabetic foot ulcer. And here, a severe sacral pressure ulcer exposes deep structural tissue, muscle and bone left completely unprotected. Wounds in this state represent biological systems caught in a destructive attractor, a permanent stagnation that breaks the orderly 21-day timeline of normal repair. Across different etiologies, these stalled wounds share specific macroscopic traits, notably persistent surface infections and drug-resistant microbial biofilms. Beneath those biofilms, the microscopic environment is chaotic. The wound bed is overloaded with pro-inflammatory cytokines and senescent cells that actively ignore reparative signals. Because the progress of healing is defined by how these competing cell populations grow, move, and die over time, we can formalize this cellular tug-of-war as a system of nonlinear ordinary differential equations. By assigning mathematical variables to specific cell populations, we can calculate the exact boundary where the healing sequence definitively collapses. Applying the rigorous mechanics of dynamical systems to severe clinical pathology gives us a solvable framework for an otherwise chaotic biological failure. The mathematical engine begins with a single driver, the initial wound size, or WS0. The initial tissue damage invites our first external variable into the system, pathogens, denoted as P. The immune system counters with rapid recruitment of inflammatory cells, node N, which engage the pathogens directly. For the wound to eventually close, the system must enter the proliferative phase, heavily relying on the migration of fibroblasts. These fibroblasts act as the construction crew, synthesizing and laying down collagen to rebuild the structural matrix. But this biological network contains an inherent conflict. It operates as a nonlinear system, governed by aggressive concentration thresholds. While the inflammatory cells effectively destroy the pathogens, they simultaneously exert a destructive inhibitory force on both the fibroblasts and the collagen. The baseline model reveals a highly volatile balance. The body's early defense mechanisms actively suppress the precise tissue remodeling cells required to finish the job. This fragile local network does not operate in a vacuum. It is deeply vulnerable to systemic clinical constraints affecting the entire patient. In diabetic and arterial disease, the primary systemic disruptor is hypoxia, a critical lack of oxygen circulating through the tissue bed. The model defines healthy tissue oxygenation using a critical threshold set at 25. This chart tracks the impact of dropping below that baseline. As oxygen falls below 25, the mathematical growth rate of pathogens, beta P, curves sharply and exponentially upward. Hypoxia presents a dual threat. While pathogen growth accelerates, the destruction efficacy of the inflammatory cells plunges. The immediate biological consequence of this divergence is that the pathogens escape immune control and overpopulate the wound bed. The system responds reflexively. It continuously pumps a panicked influx of resting inflammatory cells into the area, attempting to combat the unyielding infection. Because the destruction of these cells is modeled using Hill functions, the interactions scale nonlinearly, quickly generating a runaway mathematical effect. The prolonged artificially high concentration of inflammatory cells then completely suppresses fibroblast migration and activates unchecked collagen destruction. A single microscopic shift in oxygen availability cascades through the entire equation, turning a temporary immune defense into a permanent loop of tissue decay. Ultimately, the entire biological system is governed by a single mathematical condition, the wound-free equilibrium threshold, denoted as RW. The primary law of this differential equation model dictates that if the cellular variables calculate to an RW greater than 1, the wound mathematically cannot close. Forcing the system into a healing state, where RW is less than 1, requires a precise balance between collagen production and the natural decay rates of the cellular populations. To isolate the most critical factors in this balance, mathematicians use a global sensitivity analysis, scanning the parameter space to see which variables exert the strongest pull on the RW threshold. On this tornado plot of PRCC data, the strongest variable driving the threshold up is C infinity, the fibroblast contact inhibition constant. This mathematically forces RW higher, impairing cell reproduction. The strongest force pushing the threshold down toward healing is overall collagen density at equilibrium. The fate of a chronic wound relies heavily on overcoming the natural inhibition of fibroblasts, providing a mathematically precise target for clinical intervention. A chronic wound functions like a deep topological gravity well. The system expends massive kinetic energy, but lacks momentum to roll up the slope independently. Breaking this attractor state requires a forced external perturbation to the equations. At the bedside, this is executed through the standard clinical care framework known as the TIME protocol: tissue debridement, infection control, moisture balance, and edges. We can evaluate the first step, tissue debridement, strictly through the lens of our mathematical model. Aggressive surgical removal of necrotic tissue acts as a hard mathematical reset. It instantaneously forces the massive pathogen and inflammatory variables back down toward zero. Subsequent infection control measures permanently depress the pathogen growth parameter, preventing the system from immediately relapsing into exponential replication. Maintaining strict moisture balance alters the local physical constraints, directly optimizing the mathematical proliferation rates of the fibroblasts while actively reducing their cellular decay. Standard clinical wound care protocols function as mechanical perturbations designed to force specific parameter state changes in a stalled dynamical system. When these clinical interventions act on the tissue simultaneously, the physiological environment undergoes a rapid shift. The forced parameter changes successfully push the system's baseline back across the critical threshold, dropping RW below 1. Now, fibroblasts can finally migrate safely into the wound bed, synthesizing and depositing collagen free from hyperinflammatory destruction. This restored equilibrium allows for complete wound closure, followed by the healthy, regulated elimination of the surplus cells. By formalizing clinical pathology into calibrated differential equations, the chronic wound transitions from a frustrating bedside mystery into a precise, solvable biological system.